Welcome to Tower Talk Business Radio on the voice of Nassau Community College 90.3 WHPC. Tower Talk Business Radio brings you conversations with the top business minds on Long Island and around the nation, including expert consultants and small business owners who have found success, but are also willing to share their top tips, failures, and give gritty, matter-of-fact advice based on their first-hand experience. And now, let's get down to business with Tower Talk Business Radio, powered by the Nassau Community College Foundation.
Hello, and welcome to Tower Talk Business Radio, powered by the Nassau Community College Foundation. My name is Ray Schwetz, AVP of Nefke Business Banking, along with Denisha Boston Hill, CEO, keeper of the brand, marketing, and digital agency. And we're focused on being the premier resource for business and entrepreneurship. We bring you weekly business advice, tips, tools, and services that help you grow your business. Plus, we interview top business leaders in the industry. Now, business people are so busy. We're all so busy that sometimes there are some things that we under-prioritize or, we just kind of forget about, or, we worry about it once it's a problem. And it seems like health should be the number one concern, but of course, when we're running around taking care of things, it's something that we tend to under-prioritize. And we have a very special episode of Tower Talk today. We have a returning guest helping provide us with business empowerment today is someone that will correct this issue. He is our guest, Robert Day. He is the Chief Operating Officer of Zwanger Persiri. It's great to have you back, Bob. Thank you very much for coming on the show today.
Thanks for inviting me back.
Oh, we're excited and ecstatic to have you here because we're hoping that you're going to be the voice of reason for us. Some of the things that we should be doing that we're not.
Okay.
So I know, there's always new things going on at Zwanger Persiri. I'm sure some of the concerns are some of the same concerns. There are some things that are not on the top of my list that I don't, necessarily think of. Mm-hmm. But you have a lot going on. Specifically, I wanted to ask you a little bit about prostate cancer because that's not something that's on the top of my mind. But I'm starting to approach that age now.
Sure.
So tell us a little bit about why it's important to be screened.
Sure. So typically now the methodology that's used to kind of check to see if you're prone to or maybe even potentially have prostate cancer. It's all done through blood work. It's a study called PSA that specifically checks levels in your blood that won't tell you that you have cancer, but it can tell you that you may be either prone to it or on your way to developing cancer. And typically what happens is, it's usually done as part of a screening blood work study for your normal, say, yearly checkup.
Okay.
And if these numbers start to increase, or as I say, creep up, we start to worry that, you could potentially have the beginnings of or potentially have prostate cancer. Mm-hmm. So the standard of care right now in the urology world, if we're concerned that this blood work is increasing and you may have prostate cancer, is the urologist will perform a biopsy. Now, this biopsy is, and I don't want to get too technical, but it's done transrectally.
Okay.
All right. So they will place a needle, through your rectum, and we will sample the prostate gland. So I just want to point out a very distinct difference between what I think would be analogous to this would be a breast biopsy, which, obviously most women and men are aware of, where if you have a mammogram, which is imaging, and we detect something that looks suspicious,
right,
maybe not look normal, sometimes we're caught between, some things are obviously malignant and other things we know are obviously normal. But there's a lot of gray area in breast imaging where the only way to make that final decision would be to take a needle and guide it into the area of concern,
right,
and take a sample of tissue, look at it under a microscope and see if there are any cancer cells. But it's a very directed, very specific area that we're looking at.
Right.
So why do I bring that up talking about prostate imaging? Well, unfortunately, being a guy, this is done slightly differently.
Right.
It's done under the best way to explain it, it's a blind biopsy.
Okay.
And what I mean by that is if you think of your prostate gland, which kind of sits right behind your bladder.
Okay.
And that's why as men, as it gets large, it can cause that ever increasing problem where we get that urge that we always have to urinate because it's kind of pressing on your bladder as it enlarges.
So I'm pretty safe then if I'm able to hold it in a while.
Well, that means your prostate hasn't enlarged, which is a good thing. Doesn't mean you couldn't still have cancer cells in your prostate. So let me describe a blind biopsy, and it's unfortunate, but what we do is we take your prostate gland and we divide it into 12 different sections.
Okay.
Picture like a clock. And it's about the size of a walnut if it's normal. And what we do, or the urologist does, is he'll take a needle and put it in each one of those areas and take a sample of tissue. Why is that not a precise science? Because you could put 12 samples and unfortunately still miss the cancer.
Oh, wow.
Yeah, so you're going to go through a procedure. It's not going to be directed. It's going to be, in a sense, blind. There's some pain to it. There's certainly some possible side effects to the procedure. Mm-hmm. We could tell you that you're cancer-free, and unfortunately, we could have missed the cancer.
Gotcha.
So where does radiology now fit into this kind of different dynamic that's developing over time? Mm-hmm. If your PSA continues to rise, they still will bring you back and do another blind biopsy. What we're starting to understand more and more now is we want to do imaging with MRI. MRI is the tool of choice now.
Okay.
Recently we've developed different imaging techniques, and we have higher field strength magnets. And what I mean by that is that, I don't know if you've heard the term 3 Tesla or 3T.
No.
It's basically a camera, the MRI camera, that has higher detail or higher resolution, and we can see smaller things at better detail.
Oh, it's like a 3-chip camera.
Exactly. In fact, that's a wonderful way to describe it, Ray, that if you think of megapixels on a camera,
right?
And back in the day, we had 3 megapixels, and we thought that was great.
Yeah.
And now you have 18 and 24 megapixel SLR cameras.
Yeah.
So I always use the analogy that the older cameras, we could look at a rose petal, and I could tell you it had 5 petals, and I could tell you it was pink.
Right.
With the newer machines, the newer cameras, the 3T cameras, I can see the little dew droplets on the camera. So It's still a rose petal. I still know it has 5 petals. I know it's pink, but I can see a much more detail in the camera. So that's my analogy for 3T imaging. We just get a much higher detail of what we're looking at. So what we're able to do is, we put you in feet first.
Right.
All right. And for anybody that's had an MRI, we worry about all of the claustrophobia and the contraindications. And the study has progressed a lot. It's now we're able to perform this particular study in about 15 minutes. It's very quick. I tell people, if you put on a set of headphones that I give you, and you're a radio guy, you like music, how many songs is 15 minutes? 3 or 4 songs?
3 or 4 songs.
So I tell people, go listen to 3 or 4 songs, and I'll get you up, and I can get a very, very high resolution look at your prostate gland. So it's a matter of just laying. We call it a coil. It's just kind of a mat that lays over your pelvis, and it generates the image. We do need to give you some contrast, which is an injection in your arm, which gives us a little bit more information. But the key is, it's something that we now call active surveillance. And what do I mean by that? It means rather than just watch your blood work and see over time if your PSA is rising, if your PSA starts to rise, what we're starting to do, which is really going to become the standard of care going forward, we're going to bring you in and we're going to image your prostate gland, and we're going to get a baseline. And the hope is that it's going to look normal, and we'll stop there, and if your PSA continue to rise, we'll bring you back. If we find something, the beauty of the MRI is we're going to know where it is.
Gotcha.
Instead of just wondering where it is. Okay, the PSA is high. There's something going on, and now we're going to guess where we think it is. I will be able to look at the images and say, at 3 o'clock on the outer periphery, put a couple of needles over there because that's where the money is. And then if you come back and I tell you, Ray, you don't have cancer, I can have a much, much, much higher confidence that I was in the area that we were concerned about, and I feel a lot better about telling you you're cancer-free.
Excellent. You are listening to Tower Talk Business Radio on the voice of Nassau Community College, 90.3 WHPC. I'm Ray Schwetz, and our guest today is Bob Day, Chief Operating Officer of Zwanger Persiri. So when does somebody consider being screened? I mean, is there an age, or what would you recommend, or what would you suggest?
So I'm going to talk a little off topic, and this is going to be my opinion, the radiology world opinion. Screening is an interesting term. And sometimes I want to start with the term screening, because sometimes I think we throw radiology terms around, and I want to first make sure that everybody understands the term screening.
Okay.
So when a woman, and I always go back to mammography because I think that's a very well-known entity that people understand.
Yeah, I agree.
So your wife goes for screening mammo every year?
Mm-hmm.
What does that mean? It means your wife doesn't have a lump.
Right.
There's nothing going on. She feels fine. There's no reason to believe she has cancer. But we want to screen her and make sure, even though everything seems fine, that she doesn't have breast cancer. So that model, I think what we need to do is apply that to prostate. Why do we do a colonoscopy? You may have, right? There's no blood in your stool. There's no reason to believe you have colon cancer, but we're going to screen you for colon cancer. Mm-hmm. I think prostate needs to move into this realm where at a certain age, and we can debate that, myself, I probably say in that 45 to 50-year-old range. Mm-hmm. I think, the hope is moving forward, no symptoms, your PSA is normal. We will bring you in, we will image you, and at a minimum, we're going to get a baseline look at what your prostate gland looks like. This way, if down the road, say your PSA did start to rise, we have at a time when your PSA was normal to refer back to,
right,
when we knew it was normal, and see if there are any changes. So the hope is, moving forward, that we can take prostate and make that a screening test for men. And I think probably in that 45 to 50-year-old range will be when we start to, that's when they start to do the PSA blood work now. Mm-hmm. I would hope that going down the road, we can leverage radiology and imaging and make that the way that we screen. Not to do away with the PSA, but they can be used in conjunction.
Gotcha. Now, if someone's not really doing that type of maintenance, I'll call it, mm-hmm. What are some of the signs that somebody might want to consider getting checked?
Sure. Well, we spoke about it before. Would be the increased urination.
Yep.
Right. But the big one right now is the best tool available is that PSA study, the blood work. Okay. If that number starts to rise, there's usually that doesn't mean you have cancer, because I've seen people with very high PSAs, mm-hmm. Off the charts high, that don't. Right. People that have minimally high PSAs that do have cancer. So, but the other thing. With imaging, which is good, and go back to that term that I used earlier, active surveillance. One of the other things that I like about imaging as a tool to follow the cancer is not all prostate cancers are created equal. And what do I mean by that? Some of them are very, very aggressive.
Right.
Very, very, I hate to say this, but very, very, terminal, deadly cancers that if they're not treated quickly.
Right.
Other prostate cancers, I got to be honest with you, you'll probably take them to your grave. Mm-hmm. And if we never had PSA tests and we never had imaging, we would never even know it was there. You would technically have cancer, but you would probably outlive it. So the beauty of this active surveillance or the imaging tool to follow the cancer mm-hmm. is we can take a look at it and then on very short periods of time see if there are aggressive active changes. Because if it's stable, and we do this with many other things in radiology, one that pops into my head is I don't know if you know what an aneurysm is.
Oh yeah, sure.
So you can have an abdominal aneurysm where your aorta in your belly, your abdomen is getting large. And so typically it should be, say, a couple of inches big, but yours is 3. Well, 3 is not normal.
Right.
But it doesn't mean it's going to be something horrible happen to you. So what do? We routinely, with an ultrasound, keep an eye on it and make sure it doesn't grow. If we bring you in and it's 3 and it's 3 and it's 3, you're fine. But if all of a sudden it becomes 3.5, we're going to bring you back in 3 months and see if it becomes stable or it continues to grow. So prostate image, I think, with the ability to look at the prostate gland, I think one of the things as a guy,
right,
prostate cancer is bad on 2 levels. 1 is the cancer. Mm-hmm. 2, sometimes the treatment can really, really be debilitating. So I think where MRI and imaging can be helpful is not only to detect the cancer, but it can give the urologists and the surgeons the confidence that they don't need to be as aggressive, and they can actively watch and survey the cancer and not become aggressive until they need to be. Because some of these things that we need to do if you do have cancer, we only want to do it if you really need it.
Right.
It's not a benign procedure, trust me.
You are listening to Tower Talk Business Radio on the voice of Nassau Community College, 90.3 WHPC. My name is Ray Schwetz, along with Denisha Boston Hill, and our guest today is Robert Day, Chief Operating Officer of Zwanger Persiri. How does somebody arrange for this type of maintenance or surveillance?
So a couple of things. So if you were to have your annual checkup and your PSA was rising, I think, and what I'm going to try to encourage people to do today is at a minimum, become educated about this. Understand that there are other ways besides biopsies to actively, investigate what your prostate looks like and what it's going on. So I think what I would encourage people to do is make their urologist or who's ever managing their urology prostate care to make them aware of the fact that these tools are available. It's becoming more and more mainstream. We do many more of these procedures. I think it's becoming the standard of care. But I think the first step is to be aware that this is available to us as men. It's an option, that we don't have to go from high PSA to needles. There's this in-between step. And at a minimum, even if they're very concerned that the PSA is very high and that, they have a high suspicion for cancer, I would still argue that the MRI is a nice in-between at a minimum to direct where they're going to put the needles and where they're going to take the sample. So
that makes sense.
I think it's a surveillance, but I also think it's a tool that we can use to direct. So I think the answer to your question, Ray, would be first, you be aware of it, make sure your doctor's aware of it, and then be very proactive. And as far as Zwanger Persiri goes, we have these 3T magnets at every one of our locations, so it's ubiquitous. We do it everywhere. It's not a specialized imaging tool that we only have certain places. And it's nothing more than calling up, making an MRI appointment, no different than if you were going to get your knee done because your knee hurt.
Yep.
The only caveat I would say is we are going to ask you to take a medication or a pill that will kind of help cleanse your bowel a little bit before it. We like to have that area clean, because because there can be some the rectum sits behind it, and if there's some gas and stool there, it can affect the picture. So the only little thing that you have to do above and beyond it, what I would call a routine MRI, would be we would ask you to do this ahead of time, just the night before. It's nothing horrible. It's nothing terrible. You show up for the MRI. We will put a little IV in your arm because we're going to give you some medication. We call it a contrast that'll help highlight certain things in the prostate gland. You lay on the table. You listen to 3 or 4 songs, and you're done. You're good to go.
Not bad. Now, I want to switch topics a little bit.
Sure.
I want to talk about something that, you don't necessarily think of, especially if you're not a smoker. I'm not a smoker, but you know what? I worked in Manhattan for 11 years, so maybe it doesn't matter.
Exactly. Yeah.
But that being said, I'd like you to talk a little bit about what's going on with Zwanger with regards to lung cancer and screenings or surveillance on that.
Yeah, so this is another interesting topic, and again, we'll go back to that term screening.
Yep.
Right. So screening is, it's become it's a proactive way of, maintaining your health. It's like bringing your car in for a checkup, even though it's running fine, right? And then you may find there's the belt didn't break, but it's got a crack, so we want to change it before it breaks. So that, in my mind, that's what a screening tool is. So basically, lung screening, it's designed around people that do smoke. Okay, and the concept is it's for people that have smoked X number of packs for X number of years, and we'll put you in a category. Now, the thing is, it becomes a screening tool because you don't have a cough. You're not spitting up any blood. There's nothing bad going on. There's nothing in your mind that would make you think, oh my goodness, I think the way I feel, I have lung cancer.
Yeah, there's no sign.
There's no sign. So screening is, the government has actually stepped in, CHS, and said, you know what? There's this group of people out there. If we intervene early and get to these lung cancers early when they're small and manageable, let's screen for people that have had years of smoking history. They have no symptoms, but years of smoking history, and let's screen them. And that's nothing more than having a CAT scan.
Yeah.
Now, a CAT scan is a wonderful, wonderful test. That's literally, you go into a machine. It's not claustrophobic. It's not like the MRI. It's much smaller, much more open. But the beauty of a CAT scan, Ray, it is literally a 10-second breath hold. Taking a breath and hold it, the table will move, and we will get very small, fine, high-detail pictures of your lungs to screen for cancer. And what we can find a lot of times is we can find small nodules or small lesions that if they're not cancer, they have the potential to turn into cancer.
Right.
And if we find these, then we kind of slide you into a different category. We're going to follow you every 6 months to a year. And the beauty there is we're going to make sure it's not looking like something that's growing or developing into a cancer. If it does, we're going to intervene really early. It's going to be a simple procedure to hopefully remove it, and you'll be cancer-free. The point with lung cancer is not a good cancer because a lot of times the symptoms, when they manifest themselves, it means that it's kind of far along. It's kind of progressed kind of far, and it becomes very hard to manage. And the reason that lung cancer can be so deadly is that it doesn't manifest itself with symptoms until it's really progressed.
Gotcha.
So the whole point of screening is to try and intervene well ahead of that happening.
Gotcha. Before it spreads.
Yes.
And you mentioned breast cancer. It's funny, I mean, living on Long Island, that's the one I always think of. And as you said, that's kind of the established procedure. You know, women know automatically, oh, you know, I do that.
Right.
Especially Long Island women, I think, are very sensitive to that, and with great cause. And I agree that, you know, maybe as men, we need to be looking at that too. What's going on in that world at Zwanger?
So the conventional, way of imaging for breast cancer is the standard mammography, and there's something new in mammography called 3D tomography. That's a new way of imaging through X-ray, which is mammography, where we can kind of take the mammogram, which is typically done in what we call a 2D format. And again, I always try to be careful not to get technical, but 2D would be if you could picture a glass of water and just looking through the glass of water. All right. Unfortunately, some women have what we call dense breasts, which would be cloudy water. It's nothing wrong with you. It doesn't mean you're more inclined to have anything bad, but it just makes it harder to interpret the pictures. And what it does is it can mask or hide the cancers. So there's a new technique called 3D mammography, and basically what we do is we take this cloudy glass of water. If you could picture the jelly bean sitting in the middle of it, and I'm trying to see it, and we slice it into thinner slices and kind of removes the cloudiness and allows us to just see the jelly bean in the middle. So that's something that's been, I guess, around for 4 or 5 years now. It's kind of helped us a lot in that first step of screening in breast cancer, which is mammography. We also have ultrasound, which is another wonderful tool that we can look at the breast with. But the most exciting thing, and it's been around for a while, and slowly but surely it's becoming more and more part of the workup for cancer, is we can also use the MRI camera or imaging tool to also look at your breast. It used to be kind of a long, involved procedure. It now takes about 10 minutes. You lay face down in a coil or the lens camera that actually looks at the images, and we can get very, very sophisticated, very sensitive images that can detect cancer. The problem with MRI, the problem with healthcare, the problem with radiology is there's a cost to everything that we do. Mammography and ultrasound, I hate to say this, so bluntly, but those are the more cost-effective ways to do things. I hate to use this word, but they're cheaper.
Yeah.
MRI is on the other end of the spectrum, where that's the more expensive way of imaging, a woman's breast, but it's the most sensitive. And I think what we're learning over time is when we intervene sometimes with these higher cost imaging tools, there can actually be, because of better outcomes, cost savings. So I personally think, and any woman that I know, I recommend at around age 40, when they start to have mammograms, to have a breast MRI.
You are listening to Tower Talk Business Radio on the voice of Nassau Community College, 90.3 WHPC. My name is Ray Schwetz, along with Denisha Boston Hill, and our guest today is Robert Day, Chief Operating Officer of Zwanger Persiri. So, where do you see kind of things going from here? I mean, you talked about now the 3D technology used in screening. You don't need glasses, so that's good.
Yeah. No, you don't.
No headache there.
Right.
But where do you see things evolving?
So I think, radiology is been it's a high, it's a lot of the cost that's built into healthcare. Radiology does manufacture a lot of the cost. But I think what we're learning over time, And being somebody that's in the field, this may sound a little self-serving, but I think it's actually an underutilized tool. Because I think what we're starting to understand is intervening earlier, screening, doing things that allow us to get ahead of the problem before it actually really manifests itself. And when these things start to happen, and you get on a course of cancer and chemo and radiation, if we can intervene earlier through screening and through imaging and stop these things before they come catastrophic, there's a human part of it that we want to save your life,
right?
But there's a cost part of it too. And I think what we're starting to realize with radiology is that the earlier we intervene and the more we leverage some of these tools that we have, there can actually potentially be cost savings. And again, I know that sounds self-serving, but I can tell you that it truly is becoming the standard of care to prevent diseases. I think, the lab has a place, and your doctor looking and listening and talking to you has a place, but there's nothing like taking a picture and looking inside of you.
Yes.
That's as good as it gets.
And I would have to say that's one of the things I admire greatly about Zwanger Persiri is the fact that you are an organization that's really on the cutting edge and pushing that message, because at the end of the day, yes, it's a cost savings, and that certainly is good, but it's also, it's time back.
Yes.
It's time that you would be going through treatments. So on a human level, I can totally identify with how important that is. That rather than not checking these things, you get ahead of it. You get ahead of it, and you make it quick. What would you like to leave our listeners with as like kind of a last word on the subject, or not last word, but like a lasting word?
Healthcare, I think, I think you need to be involved in your own healthcare.
Yep.
I think you need to educate yourself, because I think, and I don't want this to come out wrong, but I think sometimes physicians kind of get locked into what they're comfortable with, the way they've treated patients in the past. I think the wonderful thing about healthcare, and certainly radiology, it's ever evolving, it's ever changing, and the beauty of it, it's always getting better.
Use those tools.
Yeah, be an advocate. Be educated, understand what's out there, understand what's available to you, and if you think it's something that that should be part of your healthcare, push for it. And if somebody says that your insurance company is not going to provide access to it, I would say go out there and demand it.
Yep.
And I'll tell you why. That's why we're so progressive with women's imaging, because boy, there's nobody that yells louder than the women, and when they want to get something, boy, do they get it. So we got to start taking care of our prostates. We got to start screaming.
All right, that sounds good to me. And where can we find you?
Everywhere.
All right.
Everywhere. Suffolk County, Nassau County. We have soon to be 30 locations. We try to be convenient. We try to make our hours convenient. We're open 7 days a week. We're open into the evenings. We want to get you in. We want to get you out. We want to respect your time, and we want to treat you nice, and we want to take really good pictures, and we want to tell you what's on the pictures.
Excellent. And phone number and website.
So the website is www.zprad.com, and main number would be 631-225-7200. That'll get you into any one of our locations. You'll get right on with a real person that will talk to you and help you if you want to schedule an appointment or if you just have a question.
Sounds good. Thank you very much for being with us today, Bob.
Thank you.
All right. We want to thank you for being with us. My name is Ray Schwetz, along with Denisha Boston-Hill, your co-host and producers. The creative director of Tower Talk Business Radio is Rudy Breedy. This is an NCC Foundation Business Leaders Council production. Visit ncc.edu/WHPC for more information. Available as a podcast on iTunes, Android Podcasts, and Spreaker. This has been Tower Talk Business Radio, powered by the Nassau Community College Foundation on 90.3 WHPC. We'll talk with you next week.